Hello everyone and welcome to my presentation. My name is Amin Shuku and I am Assistant Professor in the Department of Occupational Therapy at the University of Manitoba College of Rehabilitation Sciences. I'm gonna talk today about smart technology-enabled telerehabilitation for rural, remote and underserved populations of Manitoba. I'm gonna start off my presentation with a presentation of facts about technology used by older Canadians for health and wellness and telerehabilitation. I will then present the Rehabilitation Technology Lab and the Ambient Assisted Living Initiative we've been developing over the last 3 years. Lastly, I will present 3 major projects going on in Manitoba, which are in-home telemonitoring, telepresence, and in-home telerehabilitation. Let's start by technology use by older Canadians for health and wellness in the time of COVID-19. The pandemic has impacted our lives, and I am gonna comment on that later. However, I can say that COVID-19 has especially eliminated the need to embrace virtual care, as known broadly as telehealth. Telehealth is defined as the use of various forms of communication technology and the electronic exchange of healthcare information to provide long-distance clinical healthcare to patients. The AgeWell Network has published a report in 2020 that shows the perceptions and attitude of Canadians aged over 50 towards telehealth. The report shows promising aging landscape in Canada, as more than 50% of this population had a telehealth appointments, and 80% of them were satisfied about the services they received. 1 Canadian over 2 is optimistic about aging, and 3/4 were confident using current technology that are in most cases actually teleconsultation services. Based on that, we can see about 70% of Canadians aged 50 plus are willing to pay out of pocket for age tech. The majority agree that technology advances can help them maintain relationship, reduce social isolation, pursue hobbies, manage health, maintain mental health, and also stay safe and independent. When we look at what kind of telehealth we have in Manitoba, we find some services that are somewhat basic as compared to what technology advances offer in 2021. But those services are still very helpful about offering virtual care, especially under the pandemic. I believe we need more telehealth, though, because telehealth reduces many systemic barriers, such as access to specialized care for people living in remote area and rural area, and mitigate the need for in-home care for older adults. Telehealth also accelerates access to care for remote patients, and they have to travel less and obviously save time and money. I will present many telehealth today. However, whatever the service, there are barriers to telehealth for older adults. Actually, many older adults remain isolated from digital life because of cultural and language barrier differences. Barriers can be also socio-economic in some communities. I believe we have to find ways to mitigate that in a fair and inclusive way. Greater use of technology has been shown to improve social connectedness, health, and quality of life. A more common skill needed today is the ability to search medical and health services info on the internet, and that everyone should be able to do that. Unfortunately, that's not the case. One example for that is, as we saw during the pandemic, formal communication about the COVID-19 and how information was available via traditional media like TVs and radio, but still many of us used internet browsers, social media, and mobile apps to seek all kinds of information to understand the pandemic and all the do's and don'ts about the pandemic. And I believe actually that every single citizen should be able to do that. That was a general introduction and a bit of context about virtual care. Now, what about telerehabilitation? In 2020, we've conducted a literature review exploring the digital health technology offered to Indigenous older adults as a particular population of interest, to see to what extent technology can overcome geographical resources and cultural barriers. So we searched information online from around the world in English, in French, and we have found 26 references only. Most of the findings reported on the use of very basic teleconsultation services, such as teleconferences and telephone calls, followed by health screening technology, for example, portable devices to monitor diabetes. Two information systems were also developed for indigenous community to support patient registration process and send appointment reminders. Also, that's very basics for the other populations. We also found two health promotion applications. However, none of them is reported on telerehabilitation. That is a huge gap that I can explain in two different ways probably. Maybe there are initiatives that are not simply documented online, so our literature survey hasn't successfully identified them, or there is absence of telerehabilitation of any kind for older indigenous adults, and that is quite problematic. In my research program, I believe that aging in place as a concept has very promising advantages about keeping people in their community as they age, as long as they have certain level of independence, hence respecting their choice and reducing the burden of families and community. My concerns would be how to operationalize that, what telehealth to use, what technology to use, how reliable the care will be, and how ethical our interventions will be. In designing aging in place initiatives, I always keep in mind the basic definition of health according to the World Health Organizations, which says that health encompasses physical, mental, and social well-being, and not merely the absence of diseases or infirmity. On a personal note, I have joined the University of Manitoba College of Rehabilitation Sciences in 2018, so my development is pretty recent. Please allow me to present very briefly the RT Lab, the lab that I joined the university, the vision I follow, and how I put ideas into practice. So the vision of RT Lab is to contribute to developing rehabilitations programs that are proactive instead of reactive. I think of the use of technology to enable a more continuous follow-up with the clients and personalized care. I also believe future programs should be more participatory in engaging with families and communities as a whole, which I think will overcome the current discontinuity of care and enable a more life course approach to care. To do this, I work with health centers and government agencies as well as foundations. I collaborate with industry such as Tactile Robotics, a Winnipeg-based company, and Accompany, an indigenous-owned company, also located in Winnipeg, in Manitoba. I also work with and families and with interdisciplinary research teams across the country and even international collaborators in some context. At the College of Rehabilitation Sciences, we have built an ambient assisted living facility in the Health Sciences Center in Winnipeg, a 700 square feet smart suite that is unique of its kind in Manitoba. And that's very competitive in the Canadians' research landscape. The Smart Suite will enable not only research, but also clinical work and health professional training activities. The suite has a smart kitchen that I will show in a few seconds, a standard bathroom and a smart bathroom, and a smart bed in the bedroom. Obviously, more technologies will come later. The apartments includes already sensors and technology in my area. You are welcome to visit in person or simply go to rtlab.ca website to see how things evolve and connect with me or my team if needed. This is the VR environment that reproduces the actual kitchen where some of our research happens, collaborating with architects and a company called the Core Cabinet in Manitoba, a Manitoban company. We have created an ergonomic and smart kitchen. These environments will help evaluate and train people living with cognitive impairments, for example, to perform domestic activities and compare them to real smart suite. So RT Lab and the Smart Suite are located side by side in the Health Science Center. Having this virtual infrastructure is very helpful in supporting international remote research, so any person from around the world can use this infrastructure to collaborate with us. Let's talk about in-home telerehab. Our research aims not to bring patients to Smart Suite only, instead to build and test technology-enabled interventions that we can implement in homes and in the community. The current developments is looking at how we can use simple camera, such as security camera, to monitor the residents' person's behavior, focused on people living with dementia. As an example, we have a prototype that in step 1, take information from cameras, which will be anonymized in step 2, so that we don't record the real video of the person for security purposes and for ethics considerations. But instead, we will extract data points that we make the computer analyze using computer vision techniques, and all of that in the cloud. The information's processing is almost real-time, as you can see in the top left corner. In step 3, the relevant information, such as someone falling or being in dangerous situation, will be sent by message, text message, or email to an end user, for example, a family member or health professional, for further use. This digital platform is kind of background platform that will be used in several projects under developments in the College of Rehabilitation Sciences. In this prototype video, you can see my students working from his Vancouver home, where she installed the web camera, a simple one, and walked in front of it. We have received the information, which is the stick figure, only in our lab, and our homemade computer program in Winnipeg understood how many people are in the home, namely one person in this case, and how many steps the person needed to perform this task, so to walk, and at how much speed, etc. So all the spatio-temporal parameters we need. In the same way, we can monitor a person or multiple persons at home to make sure they are safe. This project was supported by the University of Manitoba and Riverview Health Center, where we try to use it to monitor the residents with dementia as they travel freely in the aisles of the Alzheimer unit. In the same way, we are trying to send the information to help them react to any dangerous event involving one or more people, with or without using objects like scissor or pen or something like that. Another type of interventions we are experimenting in Manitoba is Telepresence. A telepresence is a remote-controlled wheeled device that has wireless internet connectivity. Typically, the robot uses a tablet to provide video and audio capabilities. In our case, we are experimenting with the use of telepresence robots to help caregivers reach out to their beloved one living with dementia and both feel the presence for hopefully mitigating the condition on one side and the family burden on the other side. We plan to work with families sorry for the noise. We plan to work with 15 different families, and recruiting is in progress through the Alzheimer's Society of Manitoba. This video, without noise, is from a fundraising event where a person from outside the restaurants has called to join us and has used the navigation options to say hello to different tables as needed. The robot was not too bad at overcoming obstacle as you saw in this video. The other type of work I want to present today is related to in-home telerehabilitations. The pandemic has, unfortunately, with no doubts, that we need more in-home care. The graphs here show the number of physiotherapists per 100,000 citizens. And thinking of Manitoba in the middle, the graph in the middle, we can see that we have 72 physiotherapists per 100,000 citizens, very similar to the Canadian statistics, but only 28 physiotherapists per 100,000 inhabitants in the rural settings versus 40 physio per 100,000 inhabitants in Canada overall. The graph to the right shows in percentage how many physiotherapists are working in rural area, and we can easily see that Manitoba is 10% below the average for Canada as a whole. So I believe technology, patients living in rural area and on indigenous reserve to access care by therapists working in urban centers, for example, Winnipeg in context of Manitoba. Current technologies allow teleconference sessions primarily. My research programs aims at supporting the patients and therapists dyad with more technology. Here is an example for stroke patients in particular. In most cases, clients are sent home with incomplete care, and clients with chronic stroke will come often to rehabilitation centers to receive care. Some cases are discouraged by repeated travel and extra costs related to traveling to an urban center. Beyond providing consistency in training, technology can provide flexibility for both patients and therapists, as I will show in this example. On the screen, I'm presenting the Active at Home Post-Stroke Program, or HOME PSP, a self-paced program that combines physical and cognitive training offered over 3 months to improve the conditions of patients with chronic stroke. The physical training is provided via tablet or phone application that we developed, while the cognitive training is offered via a VR headset or virtual rehabilitations in a virtual rehabilitation environments that we have developed as well. The physical program focuses on balance, resistance, cognitions, and stretching, while the cognitive program includes time-based activities such as brushing teeth or taking lunch, and event-based activities such as taking keys to drive a car, or closing the door, or taking medications. We are recruiting our first patient this winter, and we aim for a total of 60 persons in Manitoba. For our first round of testing or pilot testing, we need to evaluate the participants in person before and after the program, and the rest of the program is offered totally remotely. Probably we will need to call the patients to check on them and make sure technology is working correctly. That's to be tested, actually. The participants will engage in 48 sessions over 3 months, alternating 24 physical sessions and 24 cognitive training sessions, following a cycle of 2 sessions with the tablet and then 2 sessions with the VR headset, etc. So this is a kind of hybrid telerehabilitation needing minimal travel to evaluate the participants. The last development and the closer to the market is iManus, a portable hand telerehabilitation platform for home-based treatment of clients with stroke. The smart gloves technology emerged from 3 years research and development, and its development became even more interesting as we faced pandemic-related restrictions. Regardless of the pandemic, we knew we want to serve patients living in rural, remote, and reserved populations in Canada and in the world. The platform is made of a pair of sensorized gloves and therapeutic equipment ship it to the patient's home. A patient's mobile application you can see to the left, connected to therapist software, as you can see to the right. We offer the first of its kind hand rehabilitation platform that allow monitoring based on meaningful indicators. The smart gloves reliably measure hand and fingers range of motions and hand tremors based on unimpaired hand data. That's one piece of the innovations. These data add to the subjective evaluation therapists currently do, which are not enough, and enable enough to treat patients, and enable the therapist to personalize the programs based on numbers they can show and share. We developed a bank of videotaped hand rehabilitation tasks with a physiotherapist expert, so that the therapist can customize program, so the end user therapist can customize program to meet every patient's needs. The therapist can also add their contents with only a few mouse clicks, for example, by dragging contents from YouTube channels or creating their own video in their clinics and load them to the system. The therapist and patients will be able to use our platform in two ways. They can use it synchronously by e-meeting with their patients by e-meeting to use our platform and their usual teleconference platforms such as Zoom or Skype, or asynchronously if the therapist's presence is, if not, needed. We aim to provide access to hand rehabilitation care to populations who have not access otherwise. We also aim to provide the clinicians with continuous quantitative data so that they are better served. I believe data-driven decisions and personalized care are two pillars of future rehabilitation, and this is where we are headed. I would like to thank you so much for this, for your attention. Before ending this presentation, I would like to thank all the people and the institutions supporting me. So I would like to thank the Health Science Centers in Winnipeg, Research Manitoba, Riverview Health Centers, MyTax, and the University of Manitoba. I also would like to thank the foundation that are supporting my work, Marsh of Dimes Canada, the Lodge Center, and the Victoria General Hospital Foundations, my industrial partners, Tactile Robotics and IA companies, all the patients and family that are enrolled in my projects, all my collaborators from rehabilitation sciences, from engineering, from computer science, and from architecture and design, and obviously all my students who are doing wonderful work in the laboratory and at the University of Manitoba and some other universities. Thanks so much for listening, and I hope you liked my presentation. Thank you. Thanks again for your attention. If you have any question, please feel free to reach out to me by writing to amin.shuku@umanitoba.ca. Thank you.